So before everyone sees this and says, "Oh, no, not watching this. I don't want to go over the terms. I can just look at it later." This is my background for right now. I'm going to give you an explanation of what we're going to do in this video and how long it's going to take and all of that. Before I even start, I want to say I apologize. It is apparently Super Bowl Sunday, because I knew there was some game going on because I hear lots of screaming. I don't even know if it's on yet. My dogs are a little bit on edge and have been barking, so my apologies to begin with. The second thing is, as I had mentioned prior, of course, this is going to be recorded lecture. There is no homework for this week. Or for like the stuff that I've done. Everything that's basically posted, it's videos of either me doing something, which right now is going to be going over the new terms that I added to the Quizlet. It's not going to be a huge explanation because we really did get a very nice foundation. And in 2 weeks, we do another recall, and it's going to have to do with schizophrenia and depression because that's the movie day, which I already explained, and we'll do both. So with that said, I have posted, this will go along with, so I posted the 8-minute video that I told you that we were going to watch, unfortunately, but we didn't have time, that 8-minute video, as well as 2 other short videos in this same area where this video is going to go. And anytime I ever give a video or we watch it in class or something like that, if we watch it in class, I post it under the resources or if it's going to be a video that I might use potentially on a test or a quiz, but if you'll see it on the study guide, I will put it under the resources. So you'll notice they're in 2 different places, the ones that I put today. If there's any confusion, I did that on purpose. So, so and this will help you on quizzes and tests, I use these questions that you are starting to see. I think from now on, every homework assignment week, you'll start to notice the NCLEX questions. And as I mentioned before, you'll always get the points as long as you try. We'll review them in class. I'll try to give you tips and tricks since I work for Kaplan and, help you the best I can. And then I have that little resource area above there with the answers highlighted so you don't have to go looking for them. So I try to make it, easy enough for you, but then you also learn at the same time. So what we're going to do for this video is I'm going to really distinguish the difference between positive and negative symptoms in conjunction because it's on some of these cards. We're going to fly through the ones we've already done. And then I think I added maybe like 12 or 15 more. And I will briefly describe them because there's not a lot to describe from them. You'll see, because like 5 of them are medications and you just need to be able to recognize that it is an antipsychotic, which I'm going to actually get into a little mini lecture right now. And then the next video I'm going to post is going to be the whiteboard stuff. I think I've got it down where I can actually use the whiteboard on Zoom, but either way, just so you guys get every aspect of every way I can possibly show you this, between somebody else explaining it, different types of videos, Quizlet, my voice, whiteboard, all of that. So I expect this to be about a 40-minute video, and then the next one probably to be about a 30-minute video, because really it's just reiterating and showing, and maybe not even that long. Either way, it's, like I said, not going to be more than an hour and a half of me talking, however we chop this up. So let's get started by having a short conversation about the difference between why, when we were practicing it on day 1, I had said, and I did mention positive symptoms, but I do kind of interchange my wording sometimes, and I forgot to mention this, and that's why I did that very long announcement with the picture. So I'm going to distinguish that for you today, as well as I believe one of the videos does, but here we go. So there are 2 types of antipsychotics. We have the typical and the atypical. I do not think it is important for a generalist to need to know, you have to know, if I ask you about Abilify, is that atypical or typical? I'm never going to ask you that. If you have a great interest in that, and the NCLEX is not going to ask you that either, then, feel free to know that information. I will be completely honest with you. I don't know all of them. I know that Haldol is typical and Zyprexa, Abilify are atypical. Like I know some, but I don't know all of them. And that's why we have drug books and whatnot. So the reason I'm trying to distinguish this is this reason. So the first generation are called typical. The second generation are called atypical. Why that is important. So pharmacology, maybe you guys have reviewed this, but the hope when we come up with new medications is to, of course, have them maybe be a little bit more effective. But as you know, we all take in medications and metabolize them differently, as well as lower side effects. That's a huge part of it. And I've said this several times, and I'm sure you've heard it several times, and I'm sure you already know this, but I want to make sure to say it. Just because I give someone a medication that's fairly old, meaning not like old, like it's been sitting in the bottle, but I mean, it was made a long time ago, does not mean that it's not going to be effective for somebody. And that's the one that just happened to work. And it's amazing. So I really want to distinguish that. Now, first generation, again, called typical, second generation called atypical. If you want to remember that, how I remember it is you want to get an A, right, in your classes. So atypical tends to have less side effects and tends to have less negative symptoms. And I'll explain why. So in class last week-ish, we had talked about basically how too much dopamine in the brain, and I just said limbic system as a generalization because it's a lot of information, but now we can start to unravel it a little bit because now you have a much better foundation. So dopamine in the limbic system, technically dopamine in the limbic, mesolimbic area, because there's different areas in the limbic system, but specifically in the mesolimbic system, if you have too much dopamine, then that is going to cause positive symptoms. So we did talk about that, but I just said in a very general term, if there's too much dopamine in the limbic system, it's going to cause positive symptoms. And that is what? And then you guys would answer. So now I'm going to really explain it because it was on your worksheet and I honestly completely forgot to just kind of mention this. So I said, oh, no problem. That's why we do 2 of these classes, because there is so much information, but I also don't want to overwhelm you to the point of stuff where it's not completely important for what is important for you right now in your education. Okay. So I'm going to say it one more time. Too much dopamine in the mesolimbic area, that's too much dopamine, causes the positive symptoms of schizophrenia. And as you saw in your worksheet, we also have a mesocortical area as well. They're both in the limbic system. They're right next to each other. Unfortunately, we have too little dopamine in that specific spot. And that's how schizophrenia and our symptoms present. Too much dopamine in the mesolimbic, too little in the mesocortical. I never really test. I mean, sometimes with the BSN students, I want you to know it regardless. I don't usually test on it, but I want you to understand. And I want to also, because I'm sure at least half of you are thinking, well, wait, if antipsychotics decrease dopamine, isn't that going to potentially cause them to get more negative symptoms? And that's what I want to tell you about right now. And once I distinguish those two, we'll get to the Quizlet so that we can wrap up this video and I can get it posted. And then the whiteboard one, I have it all drawn out. I just need to see now if I can get it on the whiteboard here on the actual Zoom. So how this happens, and please keep in mind, we don't know every single thing. Some of this is, I mean, like the dopamine having too much, we understand that. But sometimes, I mean, you might look at one source and it might have a little bit of a different, it's pretty much saying the same thing, but it may have a little bit of a different twist to it. We don't understand everything 100%, but this is basically all the research scientists we definitely know there's too much dopamine in the mesolimbic system that causes positive. That we know for sure. Now, this is what happened. So we had the first generation of antipsychotics. There are, and you don't need to remember this, I think it's helpful in remembering and being able to put the picture together, because if you're not understanding and you're just memorizing, you're not really having it stick in your hippocampus, right? Where you have memory. So we have 5 different areas of dopamine, and we call them D1, D2, D3, D4, D5, and those are the receptors. So the first generation, the typical antipsychotics, work only on the D2 receptors. That's it. So unfortunately, that has a lot to do with the availability of the mesocortical area. And we know that the mesocortical area has to do with the negative symptoms. So not everybody, but you are more likely to have your dopamine levels go even lower in your mesocortical area, which they already are. So baseline, you are diagnosed with schizophrenia. Baseline, you should have, this is how you're diagnosed, or how the brain has looked on what, all the tests that they've done. Baseline, if you have schizophrenia, you have too much dopamine, we know that, in the mesolimbic, and too little in the mesocortical. You already start off like that. Now, if you go to, okay, well, we see these symptoms, we see, oh, okay, no problem. We're going to give them a first line generation typical antipsychotic. It has more of a likeliness of having side effects, such as things we've talked about, tardive dyskinesia. I posted a really good video about that, kind of telling the differences. I will never test you on that, but there are differences. I just use EPS as just the general term. But I also think it's important for you to know that there is a difference between them. Some being more rigidity, some being more spasticity and whatnot. But let's go back to this so we don't get confused here. So the other thing about the first generation medications is, okay, so tends to have more side effects, not for everybody. And it has more of a chance to cause more of a decrease of dopamine in the mesocortical area, which is what we don't want, right? Because that's going to potentially have you be more isolated, depression, all of those negative symptoms that we talked about. Even though it's still helping your positive symptoms because it's doing its job, it may not be. So if we notice that in a patient and they're on a first generation, what do you think we're going to do? We're going to switch them to probably a second generation. And let me tell you why. So now we have our second generation, which is our atypical. That means newer. Remember, we want to get an A. So think of that as like newer, hopefully better. Tend to, but not always, cause just less side effects in general. That goes for any medication. That's why we make new medication, is we're trying to make it make money, I guess, right? We all know that. But the hope is to, have less side effects. We learn more technology. That doesn't mean that a medication that's older, made further back in time, it couldn't potentially help someone when they've tried 10 newer ones and boom, on the 11th try, that sounds like a lot, but let's just go with it, that a first generation of a medication may be the saving grace. So now here we go. I see this happening to my patient. I say, okay, they're having a lot more, their positive symptoms have decreased, but they're really, their affect is flat. They're much more depressed. That is going to indicate to me that there's probably dopamine even going lower. And remember, the first generation only works on dopamine D2 receptors. Now, the other ones, the atypical, work on more than just D2, as well as you've hopefully read in your book, work with serotonin, norepinephrine, other things that help us feel a sense of wellness, motivation, and those types of things. So this is why understanding the neurotransmission and making all of these connections can be so important, because now we know why. Okay, now that makes sense. So that's why I say, in general, the most common and typical thing, and you can almost watch any video on schizophrenia if they're doing a lecture and it's going to say this, the most commonly talked about neurotransmitter and has to do with schizophrenia is dopamine. It has to do with dopamine levels in one place or the other, right? Whether it's in the mesocortical or mesolimbic. So I'm going to say this one more time, and then we're going to move forward. And of course, if you have questions in class or, email me, whatnot. So the positive symptoms are caused by an increase of dopamine in the mesolimbic area of your brain. The negative symptoms of schizophrenia are caused by having too little dopamine in the mesocortical. Positive symptoms are hallucinations, illusions, and delusions. Every other video I ever watched, they don't say illusions and they say cognitive thinking. Same damn thing. I mean, really, right? It's the same thing, because you have trouble thinking, you're having psychosis. But I like to add in illusions because a lot of people don't. And cognitive thinking to me goes with all three of those anyway. So just in case you see that and think, well, why doesn't she talk about that? I do, because hallucinations, delusions, and illusions all are cognitive impairment, right? So those are your positive symptoms, and that is too much dopamine in the mesolimbic. And then our negative symptoms that are in our mesocortical area, such as isolation, depression, lack of affect. So I hope that gave you a better picture and idea of what's going on and medication wise and why we may switch and all of these things. So let's go ahead now and let's jump into the Quizlet. The ones we've gone through, I'm just going to fly through. The other ones I'll give more information, but like I said, a lot of them are like medications you just need to start remembering. So we have our first one here. Let me make sure this is for you guys. Yeah, San Jose State. Okay, so the first one we have here is Abilify. So, and I put the other name for some of them I didn't. But I will usually say, I always forget if it's generic or brand. We all have our thing, right? So we have Abilify. So Abilify is an antipsychotic. I think I put down 7 medications for schizophrenia, whether it's Cogentin, which helps us with side effects of antipsychotics, such as tremors, tongue rolling, EPS, extrapyramidal symptoms, which was on your last quiz, worth 2 points. So just recognizing it. I'm not, this one I know is a 2nd generation atypical, but I do not expect you to remember that. I just want you to be able to look at it and be like, oh, okay. And when we talk about depression, you'll learn a little bit more about Abilify, because it actually can potentially be a wonderful adjunct therapy with antidepressive medication. A very low dose of this, I've seen just amazing results. Not with everybody, but when it works, wow. But we'll learn about that when we talk about depression. So Abilify, that is an antipsychotic. That's all I want you to know. Be able to look at it and understand that. So if on your, let's say, midterm, let's say on your study guide, I write Abilify, that means, and I'll usually write if I want more specific things with it, but I'll write, know the classifications of the following medications, and then I'll do a list. What's a classification? We know classification is antipsychotic, antihistamine, that type of thing. So Abilify is what? It is an antipsychotic. Moving along. And I'm sorry, these are not in the order. I put them in a very specific order of medications together and whatnot, but it's not doing that. So let's just do it. So Abilify is a new one. Again, that's a antipsychotic medication. And I am going to get these posted. For whatever reason, I've done this so many times, but I forget how. I know it's very easy, but I do plan on posting my, my, whatever these are called, Quizlets. TCON. A TCON is a temporary conservatorship. Let's keep it simple. T means temporary, conserved. We talk about that in conservatorship. It basically means that it's, unfortunately, we have somebody that's not able to make sound decisions, and it can last up to 60 days until that runs out, and then you need to go on a full conservatorship, meaning that somebody, whether it's someone someone in the court system, and this does have to do with the court system. You can't just do this on your own. There is a judge involved. So TCON is important. I've never quizzed on this either. I'm just trying to throw in words in here that you might see in a chart, and then you'll understand and be like, oh, I know what that means. And then it's going to make your whole experience hopefully better. So TCON is temporary conservatorship. So it's temporary up to 60 days. Cogentin, that is not an antipsychotic. This is a medication. Remember, we talked about it works with acetylcholine, and I never asked the nitty gritty of it. But remember, acetylcholine in the brain makes our nerve systems go very quick, and so that we think quickly, and that can cause, so if we have EPS symptoms, extrapyramidal symptoms, tardive dyskinesia, Parkinsonianism, this can be something that can really, really help. And so this medication, this is other name, it helps to slow down these nerve impulses. Therefore, remember, if someone's on an antipsychotic and they're having EPS symptoms, we can give them Cogentin to help manage these symptoms. Another one of the medications is Benadryl. I mention it. So, and I mentioned it in class as well. I may eventually just put a line there, right? Benadryl. But conservatorship, we just talked about. This is not a TCON. This means conservatorship, that you went to the judge, and it doesn't mean it's going to last forever, but somebody else is making your decisions. That's really all you need to know. And I mean, you can read right here, because they're just deemed not to be able to make the best decisions. We see this not just in mental health, but other places as well. Another very popular place we would say it would be in a skilled nursing facility or somebody that has dementia. We know what the 5 hallucinations are. I'm not even going to go through that right now because this doesn't need that to be that long of a video. Is tardive dyskinesia a type of EPS? Absolutely it is. Tardive dyskinesia, if you watch the video, it talks about, I think it's hard. These words are so hard to say, but it does talk about dyskinesia, Parkinsonianism, and all of that. So please, I definitely urge you to watch those. NMS, we know, is neuroleptic malignant syndrome. This is the one that unfortunately can cause death. That's very important. I put this at the bottom today. So I will ask you if I'm going to test you on it. I would tell you if I'm going to ask for symptoms, I might say no symptoms of, but if I just put NMS, that means I want you to know what it is and that it's life-threatening. And I can't remember if that I put that. I'm pretty sure that's on your going to be on your quiz for 10 points. I'm pretty much I put down NMS. So just understand kind of what it is. Understand that it's going to be in the form of a question, who are you going to see first? I'm just going to tell you that right now. So priority. Psychosis, we know, is a detachment from reality. Parkinsonianism versus tardive dyskinesia. Go ahead and please watch that video. But basically, the main thing to remember, I guess, I didn't even put an answer. Tardive dyskinesia is where you're having the symptoms of EPS symptoms over 6 months. Parkinsonianism doesn't necessarily have to be that way. And like I mentioned, I think twice so far, I'm now just using that umbrella term, but I'm putting the video there so you do know that the differences between some are muscle rigidity, some are muscle spastic, but they all kind of, it has to do with muscles, movements, and involuntary movements, right? All EPS does. So this is on that video that's going to be, once I post this, it's in that same text box. A Reese, I do not test or quiz on this either, but you will probably see this in charts when you're in mental health. That has to do, it's kind of similar to a TCON and conservatorship. It basically means you don't have a choice. You must take your medications. You're deemed not to be able to make that decision. And then the physician, PA, or nurse practitioner will basically give you the injectable form of the medication. And if they have to, they'll do a takedown, and you don't have a choice. You have to take medication. If medication doesn't come in an injectable form, they'll use another one that's similar, or they'll change the course of treatment a little bit. So that's what a Reese is. Same thing. I will not test you on that. Okay. And you'll know because I'll write it on the study guide, but I never do. This is more for you. We know this is DSM-5. We know this is homicidal ideation, gravely disabled, not able to care for oneself, not able to feed. So sorry, you were unable to shelter, food, take your medication. Seroquel. So far we've talked about Cogentin. We know that's not an antipsychotic. That helps with EPS symptoms. We talked about Abilify. That is an antipsychotic. Seroquel is also an antipsychotic. So, and probably a lot of you have heard that. It can be used off-label for sleep and for bipolar, but that's not what we're talking about. It will be brought up when we talk about that, just like Abilify can be used as an adjunct with medication and with depression, but we're not talking about that right now. So far with the medications we've talked about today are Abilify. What classification is that? It's an antipsychotic. Seroquel, antipsychotic. Cogentin, it's not an antipsychotic. Knowing that it is not an antipsychotic, it helps EPS symptoms. And then there's some more medication. We talked about Invega before. That's the injectable form of an antipsychotic that comes in an IM injectable form. Either can last 1 month or 3 months, depending on which one you get or which one you have prescribed from someone. So that is what we need to know right now. So Seroquel, what is the classification? It is an antipsychotic. Yes, you can use off-label. Some of them I put them, some of them I didn't because I did this on different days. But you don't need to worry about this right now. I just need you to understand at this point that Seroquel, antipsychotic. Abilify, antipsychotic. Invega, antipsychotic. What makes Invega different? It has an injectable form that can last up to 3 months, because Abilify also has one. So does Haldol. But I will always ask you specifically, if I said what makes it different. It's an IM injection, and there is one that lasts for up to 3 months. B52 injection. This is one I made a little boo-boo. Nope, not with you guys. That was with Mission. I put Haldol in the wrong, I put 10 milligrams, not 5. So B52 injection, that is a chemical restraint, and that has, it's in 2 injections. One is 50 milligrams of Benadryl, and then the other 2, which are mixed together, are 5 milligrams of Haldol, 2 milligrams of Ativan. If I didn't say this in class, I just want to say it really quick. The reason why we do 2 is because the Haldol and the Ativan can be mixed together. There's no you know how some meds, they don't, if they are mixed together, it changes the dose, or they don't, they might kind of congeal. Fortunately, we know this. It's the Haldol and the Benadryl that don't mix together. So that's why we put these 2 together, which is the Ativan and the Haldol. These have no problem going together. So how I think if just because I like to know like why, I think hell no. So that's why we can't put it with Benadryl. It's because the Haldol and the Benadryl don't mix. I won't ever ask you that, but if you care, that's why. So this is what a B52 is. It's a chemical restraint. And I won't ever test you on how much is in which thing, how many syringes. I just want you to know that B52 is a chemical restraint. If you ever Google it, it's actually, they have a cocktail, like a literal cocktail that you drink called B52. So, and it's a shot. So I don't know if that's where they got it from, or they made it from, I don't know, the chicken or the egg. Okay, another one, clozaril. And I have trouble saying that, so I say this, clozapine. This one also is an antipsychotic. So the difference is there's 2 kind of things. So Invega, we know what makes it different. Clozaril is a little bit different too. And I did write on here. So this one, we go low and slow. So you'll be provided this information. Don't forget study guide, all of that. If it's on there, your study guide's already ready. It's up. So whatever's going to be on, this is all stuff that might come up on the final. I'm sorry, probably the midterm. And it will be on the study guide. So it is an antipsychotic, but this one tends to have potentially more side effects. We have to do other things. We titrate it very slowly, and there's a titration, oh my goodness, titration schedule. So start low and slow, because we definitely do not want to get the white blood cells too low. So we draw blood usually once or twice a week, especially when you're first on it. So you don't need to remember that in this moment, but we've talked about now Abilify, Seroquel, Clozaril, and Invega. Those 4 are all antipsychotics. Oops, sorry about that. Off-label, we know what that is. Schizoaffective disorder, we didn't really talk about, so I'm going to just basically tell you this. Because we have so many diagnoses, and they're hard to tell the difference. I am pretty sure I said this out loud in class, is, for example, someone being manic, ADHD, and anxious may present very, very similar. And so it can be really difficult to know what's what. And sometimes it's like, well, maybe it's more than one thing. So when they redid the DSM-5, they actually came up with a new disorder, or diagnoses, to better say it. So it's called schizoaffective disorder. And what that means, and I just keep it super simple, it means it's symptoms of schizophrenia and symptoms of a mood disorder put together. So you may not have psychosis, but you're having or maybe you're having some psychosis, but not something else that fits under schizophrenia. And same thing with a mood disorder. And how it's basically you're having both. You're having symptoms, and this is in the DSM-5, so it will tell you how to diagnose for it. So if I ever asked you what two diagnoses make up schizoaffective disorder, you can say schizophrenia and a mood disorder, or schizophrenia and bipolar disorder. I don't like schizophrenia and depression. I know that sounds like, why? That's a mood disorder. I just don't. Because it usually doesn't present that way. But I think I'm going to just kind of let that go. And I think I used to say schizophrenia and bipolar, but I like it's schizophrenia, it's signs and symptoms of schizophrenia mixed with a mood disorder. That's what it is. And we can use, different medications depending on what the symptoms are. Just as any diagnosis. So if someone has schizophrenia, they're probably not just going to be taking an antipsychotic. There's probably going to be other medications in the mix, but having the antipsychotic is very important. Not that I don't believe in holistic medicine, but unfortunately with schizophrenia, if you're having those positive symptoms, this is, in my experience, I have never seen anyone that has a true diagnosis of schizophrenia be able to function without one. But we will talk about other ulterior modalities, about other diagnoses, because I do believe that there's not just one way, and we want to help our patients, right? If they don't buy into how we're treating them, not verbally or whatnot, but how we're doing the treatments, that's not what we want, right? We want to try to meet our patients where they are. Invega, we already talked about. It's an antipsychotic. It's an eye injection, can last 1 to 3 months. So for positive symptoms, is it too much or too little dopamine in the limbic system? We know for positive symptoms, yes, we have an increase in the mesolimbic area. Now, I may give a question just like this, and I only mention limbic system, and every other area has nothing to do with the limbic system. You're going to put limbic system. I may not say mesolimbic, and I will never try to confuse you and say limbic, mesolimbic, mesocortical. I'm going to be straightforward. I am not trying to confuse you. And I usually kind of focus more on this part because this is really usually what we're seeing, but I'm not going to hopefully confuse you. Neurotransmitters, that's how the brain communicates, up to 72 hours. Thorazine, that's another one. That is an antipsychotic. Boom. That's the classification, antipsychotic. So we have Abilify is an antipsychotic, Seroquel is an antipsychotic, Invega is an antipsychotic, Thorazine is an antipsychotic, Clozaril is an antipsychotic. Cogentin is not an antipsychotic. It helps with EPS symptoms. Illusions, you have an external stimuli, but we think it's something else. I think that my bottle of water is actually a gun. Sorry, that was dark, but that was the first thing that came to my mind. Positive versus negative symptoms, we've gone over that, but positive is hallucinations, delusions, illusions. It adds to your personality. Negative, it takes away from your personality. So that would be withdrawn, isolation, flat affect. We already talked about that. Word salad, that's a bunch of different words being put together, just like a salad, and it's not making, and there's no rhythm to it. Word clang, as you saw, I fixed that. Now it's spelled right. It has a rhythm and rhyme to it. 3 ways to help with EPS. The main one I want you to know is Cogentin, right? I put the other two, but really this is the one I want you to know. I just want you to know that there's other things we can try, but I wouldn't test you on that. Delusion, important to know. It's a false fixed belief. just show you that real quick. So you think the pill is poison, it's really not. And a lot of the times it has to do with the CIA, police, aliens, religion, things like that. Here's another one, Haldol, antipsychotic. So now we have gone through Abilify, Seroquel, Invega, Haldol. I don't remember all of them. Invega. And so I think there's 7 total. And these two I put together, not because they have anything to do with each other, but I wanted to keep the side effects close, and I forgot to put this one. So we know what agranulocytosis is, and that would be potentially being more, well, not potentially, being prone to having more infection because it lowers the WBCs, and that is a potential side effect of antipsychotics. That's why we draw blood to check for that. And then metabolic syndrome is something that can happen. And that can mean that you can gain weight, you're more prone potentially for like diabetes, high cholesterol, hypertension. And we try to watch that. So somebody is on an antipsychotic, we do weights, we do waist circumference, and then we check cholesterol more often. We're aware. And that's why it's so important to understand this, because now that we're making all these connections, now we know why the physician or whomever is asking for these certain labs, and we can keep that connection in our mind. Antipsychotics increase or decrease dopamine. It decreases it. 5250, extension of 5150 for up to 14 days. A few signs of EPS. Just in general, we know tongue rolling, lip smacking, tremors. EPS, extrapyramidal symptoms. We know that can be caused from antipsychotics. We know this one is dopamine is most related to schizophrenia. SI is suicidal ideation. 3 criteria for non-voluntary hold is 5150, 5250, and gravely disabled. This is another antipsychotic, risperidone, so antipsychotic. And sorry, those were all supposed to be in order, but they weren't. But all I need you to know is the classification. And then for those 2 other ones, Clozaril and Invega, what makes them different? Invega, we've already said. I think I've said it enough. And then Clozaril is something that we have to be really careful with because it has a high probability of potentially causing agranulocytosis. So we draw labs often and we go low and slow. So I would usually use the word, if I was going to ask you a question on that, titration, things like that. Titration, that we have to do something maybe a little bit different or keep more of an eye on. It'll be very specific. I won't try to confuse you. So out of all of those, there's 3 medications that kind of are distinctive of each other. Invega being the injectable form that can last up to 3 months. The Clozaril, with I just explained, and then the Cogentin, which is not an antipsychotic but helps with EPS symptoms. So that is the point of this video. I think we did pretty good here. I'm going to go ahead and get this posted and then work on the whiteboard stuff. So I hope this was helpful, and please write down anything if you have questions, and so that you don't forget, because I would love to answer them for you. And I will be back soon, and I hope you're doing really well. And I hope Friday went well for you guys with your tests. I know you had a big test. Okay, thank you so much.